All right, let's dive into one of the most incredible and honestly most underappreciated organs in your entire body, the liver. You hear about the heart and the brain all the time, right? But the liver is a true workhorse operating behind the scenes, and we're going to break down exactly what makes it so unbelievably vital. So to kick things off, just get a load of this number. Your liver performs over 500, that's 500 vital functions. No, that's not a typo. It is an absolute powerhouse, and it has its hand in pretty much every single process that keeps you alive and well. So, when you hear a number like that, the obvious question is, what in the world are all those jobs? What does the liver actually do all day? Well, getting a grip on its main roles is the key to understanding, well, everything about it. To really understand how the liver pulls all this off, we have to start with its plumbing. How does it get its resources? And this, right here, is where the liver is just completely unique. It has an incredible supply line. Yeah, you heard that right. It's the only organ in your body that gets its blood from two major sources at the same time. And look, that's not just some cool piece of trivia. This whole setup is the foundation for how the liver works as the body's central hub. So check this out. It's like having two completely different pipelines coming in. On one side, you've got the hepatic artery. Think of that as the high-octane fuel line, bringing in fresh, oxygen-rich blood straight from the heart just to power the liver's own cells. But then you have the portal vein. This is the cargo ship. It's bringing in all the blood from your digestive system, loaded with all the nutrients and toxins from the food you just ate. It's a brilliant design. Okay, so with all that blood coming in from the gut, you can probably guess one of its biggest jobs, right? It has to be the filter, the master chemist, and probably its most famous role is detoxification. And let's use the perfect example, ammonia. Every time your body breaks down protein, it creates ammonia as a waste product. And this stuff, it is seriously toxic. We're talking highly dangerous, especially to your brain. You absolutely cannot let it build up. So what does the liver do? It pulls off this incredible bit of chemical magic. The toxic ammonia arrives, and the liver cells just grab it. They run it through a chemical process and convert it into something completely different and totally harmless called urea. And that safe urea, it's sent over to the kidneys to be easily flushed out. Problem solved. Just an amazing, life-saving process. But wait, the liver isn't just a cleanup crew. No way. It's also a massive production powerhouse, a factory floor that is churning out essential compounds for you 24/7. And here are just a few of its greatest hits. It makes bile, key proteins like albumin, cholesterol, and something that's incredibly important, blood clotting factors. Let's actually follow the story of that last one, because it's a perfect example of how the liver works. It all kicks off with bile. The liver makes bile, and its job is to help you digest by breaking down the fats from your food into tiny, manageable droplets. Now, this is where it gets really clever. By breaking down those fats, bile makes it possible for your body to absorb crucial vitamins that are dissolved in them. And a perfect example is vitamin K. Without bile, your body just can't grab onto vitamin K effectively. Okay, so what? You can't absorb a vitamin. Why does that matter so much? What's the big deal with vitamin K anyway? Well, here's the kicker. The liver itself needs vitamin K to manufacture the very proteins that act as your blood's clotting factors. So you can see the chain, right? No bile means no vitamin K absorption, which means the liver can't produce clotting factors. It's this beautiful illustration of how one of the liver's jobs feeds directly into another. And that beautiful, interconnected system, well, that brings us to the flip side. What happens when it all starts to fail? It's never just one thing that goes wrong. It is a cascade, a total domino effect that ripples through the entire body. And this really puts it all into perspective. When the liver can't produce that protein albumin, your body's fluid balance goes completely haywire, leading to swelling. When it can't make clotting factors, like we just talked about, the risk of severe, uncontrolled bleeding just skyrockets. And when it stops detoxifying that ammonia, it builds up to toxic levels and directly damages the brain, leading to confusion and even a coma. Each failure is a critical hit. And that is such a key takeaway. Because of that direct chain reaction, bile to vitamin K to clotting factors, one of the earliest and most serious signs that the liver is in trouble is that a person starts to bruise or bleed very easily. It is all connected. So if you're going to lock anything into your memory from all this, let it be these 4 pillars. Number 1, detoxification, turning deadly poisons into harmless waste. Number 2, bioproduction, crucial for digesting fat and absorbing vitamins. Number 3, clotting factor synthesis, making the very things that stop you from bleeding. And number 4, albumin production, the master regulator of your body's fluid balance. These are running 24/7 to keep you alive. You know, we've really only scratched the surface. We've talked about 4 jobs out of more than 500 that this incredible organ is doing for you every single minute, which I think leaves us with one final thought. Your liver performs all of this for you. What can you do for it?
All right, let's get into it. Today, we're not just going through a lesson. We're actually launching an investigation. The case file? We're calling it the Jaundice Mystery. So forget your textbooks for a minute. Think of this as your official guide to becoming a medical detective.
Okay, so our very first clue is jaundice itself. You know, that really distinct yellowing of the skin, and especially the whites of the eyes. But here's the thing you've got to remember. That yellow color, it isn't the actual problem. It's a symptom. It's basically a giant yellow flag telling us that a substance called bilirubin is building up in the blood. Something's going on under the surface.
Exactly. And, you know, any good detective knows you can't just stop at the first clue. So, what is the real story behind this yellow flag? Where's all this bilirubin coming from, and why is it suddenly backing up like this? That's what our investigation is all about. We're going to dig deep and get to the root cause.
Now, to crack any case, you have to know what normal looks like first, right? We need to kind of map out the crime scene before the crime happened. So our first move is to follow the evidence by tracing the normal, healthy pathway of bilirubin through the body.
And here's our substance of interest, bilirubin. So what is it? It's just a yellow pigment, and it's a totally normal byproduct that comes from breaking down old red blood cells. You can think of it as just routine cellular recycling. So bilirubin itself isn't the villain here. The real mystery is why it's building up in the first place.
Okay, so this right here, this is our map. This is the normal flow of traffic when everything's working perfectly. Let's just walk through it real quick. Step 1, an old red blood cell breaks down and it releases what we call unconjugated bilirubin. Step 2, this stuff travels over to the liver, but, and this is key, it's not water soluble yet. So step 3, the liver works its magic in a process called conjugation, which makes it water soluble. Now that it can dissolve in water, we move to step 4. It gets put into bile and enters the intestines. And finally, step 5, it leaves the body in the stool. And hey, this is actually what gives stool its normal brown color. This 5-step journey, that's our baseline.
All right, so we've got our map of the normal route. Now the real detective work begins. We can start looking for where things go wrong. It's time to identify the crime scene by figuring out exactly where and how this whole pathway breaks down.
And this is the core concept right here. I want you to think of that pathway we just mapped out as a highway. If there's a disruption, a roadblock, an accident, a closed exit ramp, at any point on that highway, what happens? You get a massive traffic jam. Bilirubin backs up, it spills off the highway, and it ends up in the bloodstream. And that is what leads to the yellow discoloration we call jaundice.
So if we know there's a disruption, we need to figure out who or what is causing it. This brings us to our lineup of the usual suspects. And there are 3 main categories or types of jaundice, and it all depends on where that traffic jam is located: prehepatic, intrahepatic, and posthepatic.
And hey, listen up for a sec, because this is absolutely crucial. For anyone in medicine or studying to be, being able to tell these 3 suspects apart isn't just, some academic exercise. It's a core, highly testable concept. Nailing this distinction is how you're going to crack the case in a real clinical setting, for sure. Okay, let's look at the rap sheet for each of our suspects. First up, we've got prehepatic. The name kind of gives it away. The problem is before the liver. Imagine too many cars trying to get on the highway at once, like in hemolytic anemia, where red blood cells are breaking down way too fast. The liver's working fine, but it just gets completely overwhelmed. Next suspect, intrahepatic. This time, the problem is within the liver. The highway itself is damaged, maybe from something like hepatitis. Traffic just can't get through properly. And our final suspect, posthepatic. The problem here is after the liver. The liver did its job, everything's fine there, but there's a roadblock up ahead, like a gallstone blocking the bile duct. Total gridlock.
So we have our suspects lined up. How in the world do we know which one is our culprit? Well, we look for the telltale clues. It's time to find that smoking gun that's going to solve this whole thing.
Okay, let's put on our detective hats for a second. Let's think this through together. Going back to our highway map, if the pathway is blocked after the liver, A classic post-hepatic problem. What do you think happens? What happens to the stuff that's supposed to get out via the stool? And what about the stuff that backs up into the blood? What would you expect to see?
And here we go, our first huge piece of evidence, the stool clue. So normally, bilirubin flows into the intestines and gives stool its brown color. Simple enough. But in a post-hepatic obstruction, that bilirubin is physically blocked. It literally can't get to the intestines. And the result? The stool loses its pigment and becomes pale, almost clay-colored. This is a massive, massive clue.
And here's the other half of the puzzle. That water-soluble bilirubin, the stuff the liver already processed, it has nowhere to go. So it backs up into the blood, and the kidneys, which are acting like a backup filter system, they start pulling it out and getting rid of it. This causes the urine to become really dark. The body's literally using an emergency exit.
So, this combination is everything. This is the smoking gun. If a patient shows up with dark urine and pale stool, your brain should immediately just be screaming obstruction. This is the classic, undeniable signature of a post-hepatic cause. Seriously, if you remember one thing from this entire investigation, make it this.
Now, of course, as good detectives, we always look for supporting evidence, right? We want to build a rock-solid case. So in these situations, patients might also complain about pruritus, which is just a fancy word for intense itching. That's happening because bile salts are also backing up and irritating the skin. And you might also see other symptoms like abdominal pain, nausea, and fatigue. They all help complete the clinical picture.
And with that, we have everything we need to solve this mystery, every single time. So, let's wrap this up. Case closed. Here is your big diagnostic takeaway.
Let's just run through your new detective's checklist one more time. First, you've got the clue, jaundice. That tells you there's too much bilirubin, and it kicks off the investigation. Second, the investigation itself. Your job is to figure out where the pathway is blocked. Is it before, within, or after the liver? And third, the smoking gun. Use the physical evidence. Dark urine plus pale stool points you straight to a post-hepatic obstruction. It's simple, it's logical, and it is incredibly effective.
So there you have it. The jaundice mystery solved. You've got the framework, you know the suspects, and you can spot the clues like a pro. The only question left is the one right here. How are you going to use these clues the next time you're faced with this classic medical case?
Have you ever thought about how a problem in just one organ, like the liver, can set off this massive chain reaction through your entire body? Well, that's exactly what we're talking about today with cirrhosis. It's like a series of dominoes, one tipping over the next. We're going to see how that first domino falls and what happens right after. Let's get into it. So this is really the big question, right? How does some scarring on the liver lead to this cascade of problems that can mess with everything from your belly to your brain? It's not just about one damaged organ, it's about the incredible ripple effect it creates. All right, to get this whole domino effect, we've got to start at the very beginning. We need to look at that first domino, the initial injury that causes the liver to get scarred in the first place. So, what is cirrhosis really? At its heart, it's a replacement process. Just imagine your healthy, soft, functional liver tissue getting slowly swapped out for hard, useless scar tissue. This scarring is called fibrosis, and as it takes over, the liver's ability to do all of its hundreds of jobs just dwindles. And what kicks all this off? Well, it's usually not a one-time thing. It's a chronic, long-term assault on the liver. The usual suspects? You've got viruses like hepatitis, long-term heavy alcohol use, and sometimes the body's own immune system gets confused and attacks the liver. Now, this is where it gets super important. The scarring itself is bad, no doubt, but the real game changer, the critical turning point, is what all that scar tissue does to the pressure inside the body's plumbing. This is the whole key. Let's just walk through this sequence. You get the chronic injury, which leads to fibrosis. That's the scarring. Now, this scar tissue is tough and rigid, and it starts to block up the highways that blood uses to flow through the liver. It's literally like a massive traffic jam. And what happens in a traffic jam? Pressure builds up. That pressure backup has a very specific name, portal hypertension. And this right here is the term you've got to remember, portal hypertension. It's basically high blood pressure, but it's happening specifically in the portal vein. That's the major vessel bringing all the blood from your gut to your liver to get cleaned and processed. This one problem is the engine that drives pretty much every major complication we see in cirrhosis. So once that pressure gets too high, the body just can't handle it, and things start to break down. Let's look at the direct consequences, the real-world fallout from this massive pressure problem. Okay, first up, and probably the most common complication you'll see, is ascites. This is when fluid starts to build up in the abdomen, causing some serious swelling, sometimes making someone look pregnant. And it's a direct result of that portal hypertension we were just talking about. What's so fascinating is that it's actually a two-part problem. First, you've got all that pressure, which literally shoves fluid out of the blood vessels. But at the same time, the sick liver can't make enough of a protein called albumin. Albumin is like a sponge that helps keep fluid inside the vessels. So you're pushing fluid out, and you've lost the sponge that keeps it in. No wonder it leaks everywhere. All right, next up, esophageal varices. Think back to that traffic jam in the portal vein. The blood is desperate to get back to the heart, so it starts taking detours. It shunts itself into these tiny, delicate veins in the esophagus, veins that were never ever meant to handle that kind of high-pressure flow. So what happens? They swell up, becoming these fragile, bulging vessels. And this is where things get truly dangerous. Because those varices are so fragile and they're under so much pressure, they can just pop. A rupture leads to massive, and I mean massive, life-threatening bleeding. This is a 5-alarm medical emergency. And the fallout just keeps coming. That pressure backup can also cause the spleen to get enlarged, which then traps platelets and makes bleeding an even bigger risk. The failing liver also can't clear out toxins like ammonia, so ammonia builds up in the blood, travels to the brain, and causes confusion. We call that hepatic encephalopathy. And of course, there's jaundice, that classic yellowing of the skin and eyes, because the liver can't process a substance called bilirubin anymore. So we've talked about all the chaos happening on the inside, but how do we see it from the outside? Let's look at the signs a doctor or a nurse is looking for to figure out just how bad the damage really is. Clinically, we often think about cirrhosis in two big stages. Early on, you have compensated cirrhosis. The liver's scarred, for sure, but it's compensating. It's still getting the job done, mostly. But the moment those big complications we just discussed, like ascites or varices or confusion, start to show up, that patient has tipped over into decompensated cirrhosis. And that's the sign that the liver is truly failing. This is exactly why nurses and doctors are so vigilant. They are constantly monitoring. They're checking fluid status with daily weights and measuring the belly. They're assessing mental status for any hint of confusion. They're looking for any new bruises or signs of bleeding. They're glued to the lab values and are always checking the skin for jaundice. It's all about catching that decompensation early. Okay, wow. We have covered a ton of ground. So let's boil this all down. Let's lock in the absolute most important concept from this whole explainer so it really sticks with you. Here it is again. This is the whole story. Chronic damage leads to fibrosis. That's the scar tissue. The scarring creates that critical pressure backup we call portal hypertension. And it's that hypertension that unleashes all the major complications. Damage, fibrosis, pressure, complications. If you can remember that flow, you've totally got this. And to wrap it all up, for anyone studying for an exam or working in a clinic, here's the ultimate shortcut. The moment you see a patient with ascites, varices, or new confusion, your brain should immediately fire off this connection. This is likely cirrhosis, and the driving force behind it all is portal hypertension. It is the absolute key that unlocks the entire puzzle.
All right, today we're putting on our detective hats to solve a really critical medical mystery. The case? It's a patient whose mind seems to be slipping away, and all the clues are pointing to a very unexpected organ. This is hepatic encephalopathy. Let's get right into it.
So, like any good mystery, this one starts with a bunch of really confusing clues. Picture this. We're at the patient's bedside, and you can just tell something is off. And not just physically, but in their head. Let's start with the most obvious sign.
The first and most striking clue is right there in front of us. When we ask the patient to hold their hands out, we see this really strange, uncontrollable flapping motion. It's such a specific sign. So what on earth is causing these flapping hands?
Well, this sign actually has a name. It's called asterexis. And while it might look like a tremor, it's not really a muscle spasm. It's actually a brief, sudden loss of muscle tone, and the problem is coming from the brain. This is our first huge break in the case, and it points directly to a specific toxin that's building up in the blood.
Okay, so now that we have a key sign pointing to a toxin, our next job as detectives is to unmask the culprit. What is this substance that's accumulating in the body and causing these really profound neurological changes? And here is our culprit, ammonia. Now, you might be surprised to hear that your body actually produces ammonia all the time. It's just a normal byproduct of digesting protein. The problem is when something goes wrong and it starts to build up, it becomes a seriously powerful neurotoxin.
So how does this happen? Normally, your body has this brilliant little system. First, protein digestion creates ammonia. Second, your amazing liver converts that toxic ammonia into a totally safe substance called urea. And third, your kidneys get rid of that urea. The breakdown, the point of failure, happens at that critical second step. If the liver fails, the entire system just collapses.
And the difference is just night and day. A healthy liver is like a filter, right? It keeps ammonia out of the brain. But with a failing liver, that filter is just gone. Ammonia floods the bloodstream, it crosses the blood-brain barrier, and it just starts to wreak havoc, causing brain cells to swell and messing with crucial neurotransmitters.
And this is what that havoc looks like. It's a real downward spiral. It might start off really subtly, a little bit of confusion, maybe they're more irritable, but as those ammonia levels keep rising, it gets worse, progressing to severe disorientation, lethargy, and in the most serious cases, even a coma. It's a whole spectrum of decline, and it's all caused by this one toxin poisoning the brain.
So let's circle back to our primary clue for a second. Remember, this isn't just any old tremor. Asterexis, that flapping motion, is one of the most specific physical exam findings for hepatic encephalopathy. If you see this, you absolutely have to be thinking about high ammonia levels.
And there's another telltale sign we can often pick up on, a very distinct, musty smell on the patient's breath. It's known as hepatic fever. This is another one of those classic clues that points right to severe liver dysfunction. Trust me, it's a smell you won't forget.
So, we've identified the symptom, asterixis, and we've identified the toxin, ammonia. Now let's zoom out and look at the mastermind behind this whole clinical crisis, the failing organ itself, the liver. So, what does it actually mean for the liver to fail? It means this absolute powerhouse of an organ just can't do its critical jobs anymore. And it's not just about failing to detoxify ammonia. It also stops making the vital proteins that control blood clotting and maintain the fluid balance in your entire body.
So what leads to this kind of failure? Well, there are a lot of potential culprits. Chronic damage from things like viral hepatitis or alcohol abuse can really scar up the liver. And sometimes, an overdose of a really common drug is enough to just push it over the edge and cause it to shut down. Here's the thing about a failing liver. It doesn't just impact the brain. It sets off this incredibly dangerous domino effect throughout the entire body. This isn't just one organ failing. It's a systemic crisis with consequences everywhere. And it is a true domino effect. When the liver stops making those clotting factors, the patient is at a huge risk for bleeding. When it stops making a protein called albumin, fluid leaks out of the blood vessels, causing massive swelling or ascites. The immune system gets weaker, and eventually, the kidneys can even start to fail in sympathy, a really deadly complication called hepatorenal syndrome.
One of the most critical lab values we watch is the prothrombin time, or PT. Just think of it as a measure of how long it takes for a blood clot to form. Since the failing liver can't produce those essential clotting proteins, this time just gets longer and longer. A high PT is a major red flag for a life-threatening bleeding risk. Okay, we've really dug into the problem. So how do we intervene? Let's switch gears and focus on how we actually manage this incredibly complex medical crisis. Our number one weapon in the fight against high ammonia levels is a medication called lactulose. This is the first-line go-to treatment for hepatic encephalopathy.
The way lactulose works is actually pretty clever. It's like a two-pronged attack. First, it makes the colon more acidic, which traps ammonia right there in the gut and stops it from getting absorbed into the blood. And second, it works as a really powerful laxative, which physically flushes all that trapped ammonia right out of the body.
Managing these patients requires such vigilant care. For the folks on the front lines, the priorities are crystal clear. You're constantly assessing their mental status for any little changes, watching super closely for any signs of bleeding, and meticulously managing their fluids and electrolytes. It is a true balancing act. Okay, we've covered a ton of ground in our investigation. Now let's lock in the most critical, must-know info from this whole explainer. This is the stuff you absolutely have to remember.
So let's lock in these core connections. You see high ammonia, you think brain problems, confusion, and that flapping, asterexis. You see liver failure, you think bleeding and fluid buildup. And the key treatment? Lactulose, which gets that ammonia out. Simple as that.
Let's boil it down even further. This is the ultimate shortcut for any exam. If a clinical scenario gives you a patient with confusion, those characteristic flapping hands, and any history of liver disease, your mind needs to immediately jump to hepatic encephalopathy. So, we've solved the mystery, but here's a final thought I want to leave you with. Now that you know how to spot these signs, the confusion, the asterixes, how might recognizing them just a little bit earlier completely change a patient's entire outcome? That right there is why this knowledge is so incredibly powerful.
Hey everyone, and welcome. Today, we're going to do a really high-yield tour of 3 super common and super important disorders of the liver and gallbladder. We'll break down the absolute essentials you need to recognize what's going on. So here's our game plan. We'll kick things off with viral hepatitis, looking at how it progresses. Then, we'll see what exactly alcohol does to the liver. From there, we'll move right next door to the gallbladder to talk about cholecystitis. And finally, we'll wrap it all up with a rapid-fire review to make sure you can tell these conditions apart. Let's jump right in. First up, viral hepatitis. Now, here's the key thing to remember about this one. It follows a super predictable progression. It's like a story with a clear beginning, middle, and end. And because it's so predictable, it's a favorite topic on exams. So what is hepatitis, really? Well, at its core, it's just a fancy word for inflammation of the liver. And while we're focusing on viruses today, you gotta remember that other things can cause it too, like alcohol or even your body's own immune system attacking itself. If that inflammation sticks around and becomes chronic, that's when you run into serious trouble, like cirrhosis, which is basically permanent scarring, and eventually complete liver failure. You can almost think of viral hepatitis like a 4-act play. It starts with the incubation phase. This is the silent part. The virus is busy making copies of itself, but the person feels totally fine. Then comes the prodromal phase, where you just feel crummy, kind of like you have the flu. The third act is the most dramatic, the icteric phase. This is where all the classic telltale signs show up. And finally, you have the convalescent phase, where symptoms fade and the liver starts to heal. Let's really zero in on that icteric phase, because clinically, it's impossible to miss. This is when things get, well, yellow. The liver is so inflamed it can't process a substance called bilirubin, which leads to jaundice, that classic yellowing of the skin and eyes. Patients will also complain about really dark urine and, this is a big one, intense, severe itching all over their body. You see these signs together? Hepatitis should be screaming in your mind. And it's not just one virus, you know? There are 5 main types, and this table lays out their differences perfectly. The easiest way to remember this is for hepatitis A and E, think vows from the bowels. You get them from contaminated food or water, and thankfully, they almost never become a long-term problem. But B, C, and D, that's a whole different story. They're spread through blood and bodily fluids, and they carry a serious risk of becoming a chronic, lifelong disease. Hepatitis C in particular has a really high risk of sticking around for good. All right, so we've talked viruses. Now let's switch gears to another huge cause of liver damage, alcohol. Alcohol-induced liver disease, or ALD, isn't something that happens overnight. It's a progressive disease, a slow burn that gets worse and worse over time with continued drinking. This progression usually happens in 3 distinct stages. It all starts with fatty liver, which is exactly what it sounds like. Now, the good news here is that at this stage, the damage is often completely reversible if the person stops drinking. But if they don't, it can advance to alcoholic hepatitis. Now, the liver cells themselves are actually getting inflamed and injured. The final stop on this train and the most severe stage is alcoholic cirrhosis. And I cannot stress this enough. Cirrhosis is permanent. It is the point of no return. You are literally swapping out healthy, working liver tissue for useless scar tissue. It destroys the liver's ability to do its job, and there is no going back from this. But how does a drink actually do all this damage? Well, when your liver metabolizes alcohol, it creates these really nasty, toxic byproducts. This whole process puts the liver cells under massive oxidative stress and triggers this nonstop chronic inflammation. Over time, that constant battle leads to fibrosis. And that's the fancy word for the formation of that irreversible scar tissue we just talked about. Okay, so we've seen viruses and chemicals attack the liver, but sometimes the problem is more, well, mechanical. And for that, we just have to look right next door to the liver's little buddy, the gallbladder. So let's get into cholecystitis. So what is cholecystitis? It's really simple. It means an inflamed gallbladder. And in the vast majority of cases, the culprit is a blockage. A tiny gallstone gets stuck in the cystic duct. That's the little tube that lets bile out. With the exit blocked, bile has nowhere to go. It backs up, causing a ton of pressure, irritation, and, you guessed it, inflammation. The number one symptom you need to know is pain, specifically severe pain in the right upper quadrant or RUQ of the abdomen. I mean, that's literally where the gallbladder lives, tucked right under the liver. So it makes perfect sense that when it's angry, that's exactly where you feel it. And here is the absolute dead giveaway for your diagnosis. The pain gets so much worse after eating a fatty meal. Why? Well, when you eat fat, your body sends a signal to the gallbladder saying, hey, squeeze out some bile to help digest this. But if that duct is blocked by a stone, the gallbladder is squeezing against a brick wall. And that is excruciatingly painful. And this brings us to a super classic physical exam test called a positive Murphy sign. Here's how it works. You gently press on that right upper quadrant, and you ask the person to take a deep breath in. If they suddenly stop inhaling because of a sharp jab of pain, bam, that's a positive Murphy sign, and it's a huge clue that you're dealing with cholecystitis. All right, time to bring it all together. Let's do a quick high-yield review. We're going to put these conditions head to head so you can really lock in the differences. This is the kind of stuff that shows up on exams all the time, so listen up. This comparison really boils it all down. With hepatitis, you're seeing signs that the liver's function is failing system-wide, so you get jaundice, itching, dark urine. It's a systemic problem. But cholecystitis, that's all about localized pain. It's a plumbing problem. Tenderness in one spot, a specific food trigger, that positive Murphy sign, it's much more focused. Okay, let's practice. You see a test question that mentions a patient has jaundice and severe itching. Your brain should immediately go to the icteric phase of hepatitis. That combination is the classic presentation. All right, next one. A question describes sharp pain in the right upper quadrant that gets way worse after eating a greasy burger. That is textbook cholecystitis. The location plus that fatty food trigger is your giveaway. And for one last pro tip, always be on the lookout for what we call referred pain. If a question mentions shoulder pain, think gallbladder. The irritation from the gallbladder can travel up a nerve and actually be felt in the right shoulder. So if you see RUQ pain that radiates to the shoulder, that is a huge clue pointing straight to the gallbladder. So we've covered the core distinctions here, which is a great start. But here's where real clinical thinking kicks in, building your differential diagnosis. What else could this be? What other gastrointestinal issues present with similar symptoms? And what tests would you run to be absolutely sure? Answering those questions, that's how you really start to master this stuff.